So now recording, and we'll screen share. Cool. How do I move that? Okay, right, so week 5, muscles of the trunk. First thing, we're always going to recap with what we did last week. So for guys now, I'm not going to come out of this, but we're just going to take a second just to pause. So say we have 6 deep hip rotators. What are they? So the reason why I asked that is that there was a little way of remembering them, which I said. What's that kind of sentence, or the 4-word sentence that I said? What is it, and can you remember them? So if you just think about that now, the deep hip rotators, there were 6, which are technical external rotations, external rotators. So what are they? As well as this, if you just whilst you're thinking about that, I'll just carry on with we have 4 flexors and 4 extensors. So we're talking about the strains of the different muscles which are in the quadriceps. So the vastus group, and then the rectus femoris. Then we have the hamstrings, which is technically 3 muscles, but I would say it's 4 because we have a long and short head in the biceps femoris. We could actually go in and say we have more extensors of the hip because we have the long adductor magnus. But it's the same mirror image, and what you'll find again when we talk about today and look at muscles of the trunk is that there are some muscles which again mirror the adductors in the upper body. And we have 7 muscles capable of adduction. What are those? So if you split a second, if you want to write it down, what are the muscles that are capable of adduction? So I'll just give you a second to think. And again, this isn't like a specific test. I'm not trying to catch anyone out. I just want to see how much you are retaining week to week. Any look, Aaron?
Yeah, just loading it up.
Sweet. So Aaron, what I was saying is that when we do those muscles, I think as a 2D image, they're pretty, you can still get your head around them, but I think when you're able to rotate it and see, because obviously a lot of those muscles are for rotation capabilities, so that's why it'd be good to see it in that sense. Okay, so I'm going to go through. So how do we remember the deep hip rotators? I just said, please give 1 quid. That's just something that I just coined just because it was quite easy for me to remember. They've got the piriformis, we've got the gemellus, inferior, superior, obturator, externus and internus, and the quadratus femoris. Are those muscles important to know? Primarily, probably not. You know, when you're first starting off, you're not going to get quizzed on it. But as we graduate into looking really into minute movement mechanics, knowing how these 6 muscles essentially work as 1 muscle when we're going into the lower portions or hip flexion in a squat or a deadlift does become important, because then it could be an intervention standpoint if you're doing therapy from treatment, but also the muscles that you might want to target, or anything if somebody comes to you and they've actually had a scan, or they've had somebody assess them properly and the appropriate authority has said, yes, this person has a dysfunction with this muscle. If you know where it is, you know the function, or anatomy, you're good to go. But I think just understanding how we create movement and stability is interesting, which is why the external rotators, knowing them is pretty cool. So muscles of the trunk, let's get started on that. So when we talk about the trunk, I am just talking about essentially the rib cage and the pelvis and all the muscles that are layer on top of those. So that is the trunk, which you could say is the axial skeleton, but the pelvis isn't part of the axial skeleton. That only goes down to the sacrum. With the trunk itself, it's just the midsection of the body, and it's tying all together the things that we've done. So again, we've done the shoulder and the arm, we've done the hip and the pelvis, so now we're going to do everything in between. The upper portion, I'd say, have the big 3, which are the ones that you can see there. But before we go into those big movements, I think that we need to get this concept of there being 2 layers to the body. So we have this superficial layer, which is your bodybuilder muscles on top, your mirror muscles. And then we have these the deep tissue muscles that are underneath, which I've just coined them movers and managers. That's because for me, I think that some movements help us propel ourselves and overcome movement and create movement. And then we have these deeper tissue muscles, which are smaller in nature, and they help manage the joints and make sure everything moves underneath. So for me, it makes a lot more sense if we have two systems, one which is running the skeleton and then one that helps the skeleton move. And that's why we can see this layered approach there, which is just to your right. But when we're talking about the upper body, the superficial layer, so the layer on top, we have the big three, which I see as the pec major, which is the upper body glute. We have the latissimus dorsi, which is the upper body adductor, and the traps, which I'm going to dare say are the upper body abdominals, which I will explain in a little bit more detail. So, well, why explain it like this? Why should we say that it works in said manner, whereas a mirror image? And the reason why I say a mirror image is that you could get really good at shoulder injuries, or you could have somebody who has a shoulder issue and you could figure out what intervention works really, really well. So what changes in the exercise or changing in mechanics or changing in loading has then fixed the issue. And what I want people to be able to do is say, well, if I can apply that to one area of the body, can I also apply it to another area of the body? Because they do obey similar rules in when we're trying to do any form of movement. So it's helped me massively is to think is just as a mirror image, top and bottom. So when we're going to look at these muscles specifically, how do we remember the origins and insertion points? How do we remember what they do, and how do we remember, how they work from a functional anatomy perspective? Now, everybody will probably be familiar with these because they're popular muscles, the muscles that a lot of people know, and you'll hear a lot of talk about clavicular fibers and sternal fibers. But again, it's just good to understand these because again, there might be simple things here and there which you never realize, and it actually plays a big impact on the way you program or the way you'll position someone during an exercise. So the way I think about the traps is I've got in an image is the traps run from the top from breakfast till lunch in third class. So I've got this image of being on a train journey. You're in third class and you're going from the top to bottom from breakfast to lunch. So what the heck does that mean? So the way I say it is the top is the occipital protuberance, which is basically the back of the head. Then you go through the nuchal ligament, which is a ligament on the back of the neck itself on the spinous processes. We're then going from that, and this is the origin, the attachment points. And when it say breakfast till lunch, the reason why I say that is that we have from 7 till 12. So if we have this stereotypical daily eating plan of eating at 7, eating at 12, eating at 5, breakfast, lunch and dinner, from 7 a.m. breakfast, 12 is at lunch, and that's because we're going from C7 to T12. Now, again, this would be down to opinion, and it's not great in opinion in anatomy. Does everybody's lower traps insert on T12? What do you think, Aaron?
That's what I'm not sure it's something I've really thought about, if I'm honest with you, Chris.
I think
yes, I think on the whole, most people's traps attaches onto T12.
I think that it's not necessarily that they don't. When people get very, very lean, and I've just seen this when treating females who are in a very, very lean condition for either a photo shoot or a competition, sometimes strength sports as well, is I've noticed that where they're actually inserting is very, very high up, and sometimes you do have like the tendon or fascial attachment which does go down there. But if you think about T12 itself, it is probably a lot lower than we think. So the role in which the size of the traps and the role it plays is actually probably quite underestimated if you think about how far down that goes, because it's essentially going all the way down to the top of the lumbar spine, which is then we're starting to talk about lower body mechanics. Another thing about the lower traps as well is that if you look at the fibers and the fiber orientation, is that they're going to have some, not necessarily rotational capabilities to an extent, but they will also need to move when you rotate. And if they can't, then that can inhibit certain movements as well. And if they can't move, then if the lower traps don't have the ability to rotate or move in some manner, that can then inhibit the shoulder function as well. And that's when we need to look at the holistic movement, because if something is locked up or fascia muscle has become restricted in one area, it can then go further up the chain and have an impact in others. So the traps run from top till breakfast till lunch, and they travel in third class. Why third class? Well, third class is going back to the insertion points, which is the lateral third of the clavicle. So that's the third CL part. The A is the acromion, and the SS is the spine of the scapula. So third class in there. And there's that overlap between where the traps insert, and then we've got this bit where the deltoid origin slots in around that point, which is again quite interesting, because you know that they're going to have a interrelate with each other when it comes to movement. Pectoralis major, responsible for J8 joints extension, so that's closing the joint. So extension is bringing it across the body. It took me ages to get my head around flexion and extension and which direction you're going, because I was thinking about how is that extension when you're coming across, but it's closing the joint. And the reason why I'd say it is the upper body glute is that if we're thinking of the glute as what it does, we can say that primarily it's causing that hip extension to create force. So it's an extension movement. Now, where we say there's a mirror image, the pec major has internal rotation capabilities, whereas the glute max has external rotation capabilities. There is a difference there. However, when they are both propelling something going forward, they will be internally rotating as managing the joint. So we have the pectoralis major responsible for joint extension. So that's how it works as a glute. In terms of origin points, everybody will probably be familiar. We have clavicular fibers, which are obviously going to be in the inferior part of the medial clavicle, and then it's going through the costal cartilages down from all the way through the sternum point and down into the ribs, as down as I think it's about 7 or 8. Looks about 7 or 8 in the picture there. Again, some anatomy books will differ. It shares its insertion point in the intertubercular sulcus, which is on the front of the humerus. The significance is that's the same as the lat and the same as the teres major. And it's the one way of remembering it is a lady in between two majors, which is we have the pectoralis major, then we have the lat, then we have the teres major. And that's all in this little groove, which is on the anterior part, so the front of the arm, as the front of the upper part of the humerus. So those are in very, very close vicinity in that regard. So the reason why I've said the reverse of the adductors, so the lats are the reverse of the adductors, is because with the adductor we have a very, very small origin which is going on into the pubic region and the ischial tuberosity region, and then we have this massive insertion point which is the whole of the linea aspera. With the lat, it's the opposite, where the origin is a very, very large surface area, and then it's a smaller insertion point, which is that intertubercular sulcus, as we've seen. Now, in terms of what the lats do, I think what's interesting, if we think about extension movements, and we're talking about hip extension and how the adductor magnus is really a fourth hamstring, is very, very powerful in hip extension. If you think about extension of the humerus, and the lats have strong capabilities with that. They are quite weak adductors. I got deducted brownie marks. I said they were an adductor in clinic, which they said, well, they kind of are, but it's mainly that extension movement or pulling the elbow in towards the midline of the body, which is what they're going to do. But obviously, as you can see through the fibers, they can also play a big role in rotation. And when a lat is tight from a contralateral perspective, so from an opposite perspective, this is when I can see people have limitations in rotation, such as physique athletes and bodybuilders. So the amount of bodybuilders I've seen who can't physically get into a pose because the lats are so contracted and tight or developed, it just shows how that muscle does play not necessarily a primary role in rotation, but a secondary role, as it needs its full excursion through short to lengthened in order for people to be able to rotate, which is very important with a lot more activities than you think. Cool. So the deep upper body trunk muscles, spiral-like, and that's a helter-skelter for anybody who doesn't know what that is, which I had to, I knew what the image looked in my head, but then I had to type in swirly slide thing from a fair into Google to see what it was. So that is the reason why I want that there, is I want you to think about this image of a spiral that's climbing up something. And I want you to think that not only when this gets to the top, it then does the reverse on the way back down. So we have this spiral. So we've talked about this superficial layer of the upper body. Now we're going to go underneath and see what's underneath there in the deep muscles. Now, when muscles, we talk about fascia and everything, but when we know that there is muscles that share origins or insertions, we then know that there's going to be significance if one of them is restricted tight or or can't work for its full range of motion. Now, the way I see these is the deep muscles are responsible for rotation, respiration, and stabilization. So for us to rotate our head side to side, to bend our head side to side, to rotate our thoracic, these are when these guys come into play. But if they have an issue and they're weak or inhibited, we then start to have issues with stability, because that's one of their main roles, which means that the muscles on top, the superficial muscle tissue, gets contracted as a way of stabilizing. And this is when people can have very contracted upper portions of the lat because their deep shoulder rotators aren't working. They can have overactive upper portions of the trapezius because their serratus anterior isn't working. But these are the ones that we want to pay close attention to, so our superficial muscle can work how we want. So have a think about that helter-skelter in that spiral, because I do think that's a really good image, because when we look at the muscles here, we now got to see how this actually works in this spiral. Now, the serratus anterior aren't clearly on there, but with the serratus anterior, they're going to insert in like a fan motion in the medial border of the scapula, and they start really at the superior angle and then work the way down, going from inserting or originating. I see it as they do both. They neither insert nor originate on the ribs from 1 to 10. So this is on the kind of the lateral portions of the ribs 1 to 10, and that's the medial border of the scapula. That medial border then crosses over, and we have the rhomboids major and minor muscle. So they rhomboids major and minor, and they're going to go into the vertebra now, which is going to be between C7 and T5. And that C7, which is pointed out there, the reason I like this image is because we've got that spinous process of the C7 vertebra. You can clearly see that rhomboid minor going into around about that region. Then from there, we have the splenic muscles. So the Splenius Capitis is the one that I think is of significance, because that's going to be from C7 to T3, which, as you can see, it is, has it been labeled there? It's not actually been labeled, but it's the muscle which is going from the C7 point and it's going up to the mastoid process of the head. So that is now going to the back of the head and more on the right side. And the reason why I say this is significant is that we can think of this spiral that starts at the actual, if everyone does this, it would make a lot more sense. If you go into your left ASIS, so your left bony part of your hip, and then you come across your body at the front and follow it up. So you're going now across your body in a cross-sectional sling, and then you find your serratus anterior on the opposite side. So now we've gone from left hip to right serratus anterior. That's going to wrap through, go through the scapula, and then it's going to go into the thoracic region between C7 and T5. And then that's going to come across and then finish on the left. So we started on the left hip and now we're finishing on the left, in the left part of the neck. And that's going to be in the mastoid process around that back of the skull region, which is your Splenius Capitis. And these muscles are deep, so they're underneath the layers of the superficial tissue, and they're wrapping around, and we need all these to be able to lengthen and shorten and to move with strength and stability in order to create that movement without having some compensations on the superficial tissue. Okay, so Aaron, anything to add to that?
No, I'm good. I've just been playing around with images.
Cool. So good. I would say whiteboard explanation, but I haven't got my whiteboard set up. So rather than drawing some heinously drawing pictures, we can carry on. And if anybody's got any questions at the end about that process, then just jot it down, and we can go back to that. And I'll see if I can find my whiteboard to explain it if everybody doesn't understand that. But we've got muscles of the trunk. Now that is probably a very cryptic picture. But what I want to talk about now is muscles of respiration. But when we think about respiration, what are we essentially trying to achieve? So rather than just having 3 eggs here, imagine that we have a circle or a cylinder, which is the one you can see on your left, and then it increases in size and then it decreases in size. If we think about this as a rib cage, pelvis, everything in between image, we've got to think that it's at a certain level, so it's at a certain structure. Let's just call it exhalation for sake of the explanation. And then you're going to expand in all different regions, which is inhalation, because now you've brought air into the cavity, into the chest cavity, by reducing pressure. And then you're going to contract everything. It's going to return back to that size. So we go from a certain size and it inflates like a balloon, and then it contracts and that pushes the air out, and that's respiration. Now that kind of image is really important, because when we go into what muscles are there, everything's there for a reason in order to gain what we see here. So everything that we want to happen during respiration can be found with the muscle structure. So this is like structure governs function. If you just know the anatomy, you know how this process works. So it goes from a small egg to a big egg to a small egg. And then when we talk about the muscles around that, it kind of makes a lot of sense. And if I go back, not to the Union Jack, but so muscles that people don't aren't as popular or aren't as well known, we have the serratus anterior at the front, and then we have the serratus posterior superior, which is at the back, and then we have the serratus posterior inferior, which is at the back and at the bottom. And these muscles need to contract and inflate, and then bring and go back forward and going back. So they need to contract and stretch. And that's really important for proper respiration to occur. And if this doesn't happen, then we can go down the route of breathing and seeing, well, if these can't happen, where else are we going to create a compensation in order to get air into our lungs? And that's when we can go into all this crazy, really cool breathing mechanic stuff, and looking into how we compensate and how that impacts other mechanics. But again, that's for a different day. Now, what you're going to see here is obviously the Great British flag. And this is my go-to analogy or explanation for anybody when we're trying to understand the actual muscles of the trunk, or the core, or the abdominal musculature. And the reason for this is that I was explaining which way the fibers go and what they achieve. And all of a sudden I realized, well, what does that look like in my head? I was like, well, actually, it's a Great British flag. And if you just think about, we have the cross going through the middle, and if these were arrows and then it goes from diagonally, it forms this very, very powerful image which we can see. Now, if we look at the muscle trunks themselves and we look at the layers, we have the transverse abdominis, which unfortunately you can't see you probably will be able to see in your picture. I'm not sure if you see it in mine, but the transverse abdominis are going on a horizontal. So if we go back, that would be the middle layer of the GB flag. And that's the deepest layer that wraps round, which I would describe as a corset. So if you think about your lifting belt, if you think about your corset, that is your TVA. And the TVA is a very, very important muscle, not just because it does that expansion and closing like we saw with the egg picture, where the circle has to get increase in size and decrease in size, but also for the fact that if you think about it, it also has a rotation, flexion, all types of spinal mechanics as well. And that's why the trunk itself can be quite complex, because it needs to double as a stability system and a respiration system, which is why it's so easy to have issues with it if we don't know how to stabilize properly, we don't know how to breathe properly. That's when people have lower back pain issues, which we'll obviously go into. Now, the internal external obliques, the internal is secondary to the transverse. So in terms of layers, it goes transverse, then internal and external obliques. Internal is going across, so it's going from inferior to superior, so it's up to down. External is coming at the top, and it's the ones that you can see which are just underneath the serratus anterior with the external obliques, which is the third layer. And then we have the rectus abdominis, which is the line going right through the middle. So if you think about those in the direction they're going, that's when, to me, as a visual, it forms the British flag. As we go through, there's a sheath or a cross that covers them, which is your abdominal aponeurosis, which is the white thing that you can see on the image as well. In significance with that is that there's a layer of fascia which is just holding everything together around that region. From an aponeurosis perspective, it's usually the top and the bottom which can respond well to fascial treatment or scraping if done appropriately in the right manner, because I just find that really helps unlock that spinal extension, which we do need in some element. Spine explanation. Right, Aaron, you good to go?
What am I doing, Chris?
So I just want to stop the share. If I make you, I need to see more, and then go make host. So you're now the host. Will you be able to screen share for me, buddy? And then
will do.
Through.
Give me 2 seconds.
No problem at all.
Enter full screen. Screen share. There we go. Wonders of modern technology.
Yeah. It's happened to me every time as well.
Right.
We're rolling.
So we're looking at this is what you're going to go through, isn't it, Chris?
Yeah, perfect. Thank you very much.
Spinae and then the deeper layers of muscle from there.
Mm-hmm.
So, as Chris has alluded to, you find that your back is divided, well, muscles are divided into layers. And obviously he's talked through the superficial muscles. There's actually another 2 or 3 layers underneath that, which contribute, produce movement in the spine and stabilize the spine. Now on the image in front, what you're looking at there in the center is the Erector spiny muscle group, which is actually composed of 3 muscles. And that was Chris's analogy, I love sex. I prefer I love spinach because I'm a clean living. But, so from outside to in, so from lateral to medial, we have the Iliocostalis, which is the most lateral of the muscles. The next layer in, next muscle in is longissimus. And then the next muscle in is spinalis. So there's 3 muscles that compose the Erector spiny muscle group. Now, depending on the region of the spine, they are more or less present. So you find that in the cervical spine, you lose certain parts of the Erector spiny muscle group because you don't need those big muscles to support the head. You've got, that's where the lumbar spine, where the majority of your weight bearing force is where you need those big erectors. I'm going to take a layer off. Now, took the Erector spiny muscle groups off, and what you can see now, this is the Transverse Spinalis muscle group. So these are the deep spinal stabilizers. Now, again, there's 3 muscles. So you've got semispinalis, which is closest to the spine. You've got multifidus, which is the medial muscle. And then you've got rotatories, which is the most lateral of those 3 muscles. Now, interestingly, Chris was talking about core stability. And there's been some evidence, some research produced recently that suggests with those recurrent episodes of back pain, you'd not only get some weakness in some of the core muscles, but you get changes in cross-sectional area associated with those weaknesses. And one of the muscles they've found, or they've identified as being a problem, is this multifidus muscle, which essentially goes from the transverse process of the vertebra below to the spinous process of the vertebra above. So it connects the motion segment, it connects 2 vertebrae together. So when you're doing your core stability work, it's an important muscle to include, and that would be things like bird dogs. That's when you're getting that rotatory component through the spine with a degree of instability. That's what's going to target that multifidus muscle. Now, interestingly, there are more layers. So we have a deep, deep layer. If I can take a few more layers off. There we go. That's all the layers off. Now, underneath that, we have some tiny little muscles. And again, I'm not sure that we'd ever target these muscles in terms of exercise prescription, but undoubtedly when you're doing stuff that's involving the spine, these muscles are working at a segmental level. Now the ones in between the transverse processes, which are these things here, are the intertransverse muscles, and then the ones that go between the spinous processes are the interspinalis muscles. Inter means between, and obviously the spinalis relates to the spinous process or the transverse process. Cool. You all right with that, Chris?
Perfect. One thing that I forgot from mine.
Yeah.
Could you just do the QL, please, buddy?
Yeah, of course I can. Let me take it back up then.
Yeah, I think you hit the nail on the head in regards to. I think that some muscles are really nice to know, but they're not going to be applicable. You never really explain to the general pop client that you're going to be training these things. But I just think that understanding that they're there and how mechanics move is useful. So yeah, but yeah, if you just run through the QL, because it's one that I didn't put in the presentation.
Yeah, so highlighted in green on your screen there, we have the Quadratus lumborum muscle. It goes from the inferior surface of the 12th rib to the posterior part of the iliac crest. It runs through, there's a big lump of fascia in the bottom of your back, so very much like Chris described in the front of your stomach, the linea alba or the abdominal aponeurosis. At the back, we have the thoracolumbar fascia. Now, this is a really important fascial structure, which a lot of the muscles in the back connect into. So you've got a connection, an abdominal fascia at the front, you've got a lumbar fascia at the back, and that's the attachment point for all these muscles. So it forms like a cylinder. And the two big muscles that form the kind of the lateral sides of that cylinder are the Quadratus lumborum muscle. Now, in back pain, these are the muscles that spasm. So when you're pulled over to one side, or when your clients are pulled over to one side, you normally find it's this big muscle, this Quadratus lumborum muscle, which is a mover, not a stabilizer, that's gone into spasm. And that's why everything looks out of kilter, the shoulders are unlevel, the hips look unlevel. It's not that your spine's gone out of line, it's that the muscles are spasmed to protect the spine underneath. And this is one of the main culprits. So QL, in green on the screen, that's worth knowing about.
Yeah, really, the anatomy of that one's really, really important to consider. It's why one of the most bang for your buck rehab prehab exercises is the kettlebell windmill, because you can get so much rotation and stability through the scapula and serratus, but it's also that you're getting that ipsilateral QL if you do it properly with the right position in the hip, you get an awesome stretch in that. So knowing why that works and how that can alleviate back pain. Would you say it's a shock absorber as well?
Yeah. I think. I mean, the majority of the muscles, the kind of superficial and intermediate layers, I think play a shock absorbing role. Mm-hmm. Bone actually has a fairly low tolerance. Took the skeleton, took all the ligaments and the muscles off. It doesn't take much force to cause compression fractures in your bone. Part of what your muscles do, as well as create movements, is they also force dissipate. They're force dissipators, shock absorbers. And this is one of the reasons why I think when a muscle's tight, you tend to find you get more sort of injuries, because it's not dissipating that force effectively. And then that force is being transmitted into, if we're taking the hamstrings, for example, that force is then being dissipated into the pelvis, into the sacroiliac joints. And that then contributes to your pain experience.
Awesome. Cool. Okay, mate.
Good. All right. Shall I stop share?
You can indeed.
Right, we're good.
Right, good. So, don't think I need to be host for anything. So, guys, pop your questions in the chat, and then what we'll do is we will attend to the questions. And then if you need to elaborate, then Aaron and I, we can unmute you if you want to talk it in detail. I just want to make sure we can go through as many as you want. We're talking specifically about lower back questions or anything in the presentation which you didn't understand and would like us to go through again. So anything coming through. Okay. Does the psoas aid with the trunk muscles? That's a really good question. Is it a trunk muscle? It is, in a way. Would you categorize it? I would say it's deep hip.
Yeah, I think it perhaps doesn't occupy space in the trunk because it's beneath. So it goes from basically the vertebral bodies, transverse processes of all 5 lumbar vertebrae. So it's a back muscle, but it emanates through, comes underneath the pelvis, through the inguinal ligament onto the lesser trochanter. Now, so it's not a trunk muscle by definition, but I think it plays a big part in trunk stability, in back stability, because of it, the way that the slips of the muscle go in between each of the transverse processes. the inner part of psoas major almost acts like a spinal stabilizer, very much like transverse abdominis does. So I think the outer part is a hip flexor and a trunk flexor, depending if the hips are locked. The inner part of psoas, I think, contributes to your lumbar spine stability quite markedly.
Yeah, no, I definitely agree there. Really, in terms of, does it aid with the trunk muscles? I'd 100%. I would say integration of the psoas being able to contract whilst the trunk muscles also contract and stabilize is essential for back pain management. Because when we think about hip flexion, the psoas are going to play a massive role in hip flexion stabilization. So if you don't know how to control the spine through all the muscles that we've just seen in the presentation and simultaneously contract your psoas muscle, then that's when I do think that back pain can increase the likelihood of occurring. So yeah, I definitely say not directly, but it did definitely play a part.
And I think due to that, so if you think about the sitting position, so an awful lot of time in a sitting position, psoas tends to get short and tight. Now, that might affect hip movements. Conversely, that's going to pull your lumbar spine because of its spinal attachments. That's going to pull your lumbar spine into more of a lordotic curve, which potentially then is going to start to irritate the things at the back, the facet joints. The spinous processes might start to abut each other. So I think, as Chris said, both directly and indirectly, I think this muscle influences back positions, back pain, and it's definitely one that I would be trying to target if I was trying to improve someone's trunk stability, some lumbopelvic stability.
Mm. And how many powerlifters, very, very strong deadlifters have you had in you've done MET or you've done a muscle strength test to the psoas and they've been weak as a kitten?
Yeah, I mean, I think the thing with a lot of the powerlifters is their stabilizing muscles generally are usually pretty shocking. The prime movers are great, you know, they can haul great lifts on there, but actually the joint stability, both in, you know, at every joint level is pretty shocking. Mm-hmm. So yeah, I think it's not just psoas, it's, you know, it's multifidus. You get them into a 4-point kneeling position, you get them to do a bird dog, and they're all over the place because they just haven't got that fine motor control.
Cool. Matt, with the good ways to train the hip rotator cuff. I'll get to that one in a second because we may indirectly answer it in the other one. When we would potentially include a kettlebell windmill in a program as a warm up before doing deadlifts or as a secondary exercise after squats and deadlifts. Cool. I'll take this one first and then pass it down. So, kettlebell windmill is an awesome exercise. Yeah, I think in terms of, as a warm-up, brilliant, because it's going to get things moving, and it just depends on the person themselves, what they need to. If you've established in a screening that they lack lateral flexion of the trunk, or they have a tight QL, or they have such things in that area, that kind of lower compartment and then to slightly lateral compartment is restricted, then a kettlebell windmill would be great. So as a warm-up, it's a fantastic exercise. And one thing I've actually started to get people to do online now in the current situation is to just do the kettlebell windmill movement without any weight, because it's just still a good, nice mobility drill. And as soon as you add weight, sometimes you can get too much up a trap and you can get things not working. So just doing the movement without any weight is fantastic. As a warm-up before deadlifts, now, without going completely down the rabbit hole for this, some people it would be good, some people it would be bad, because you got to look at the skill set of the person. If they have very, very limited skill set, what might happen when they're going into those ranges is they may start to compensate, or you may give them too much stability, and that is a thing, or too much mobility. So I wouldn't get anybody to do it. Well, I wouldn't say anybody. I wouldn't get many people to do a kettlebell windmill before deadlifts, heavy. But I maybe want them to do it during a squat, because we want the pelvis to be able to move a little bit more freely. Freely means always with control. It's never as it wants to go, but always with control. We want a little bit more freedom and movement in the pelvis during a squat, but we want less during a deadlift. in my opinion, in terms of mechanics. But so you do it as a warm up just to get the body warm, but with lighter load and in a less intensity for the as a warm up. Secondary, after you've done your bang for your buck ones, yeah, go ahead. Just I would cater it for what that person lacks. So yeah, any add-ons, Aaron?
Yeah, I completely agree. I think in your warm up, adding a rotatory component to a movement is probably producing too much mobility, which then puts you at risk when you're starting to load that from a deadlift perspective. So yeah, I'd leave the pre-deadlift. I'd put it as your accessory movements after you finish your deadlift session.
Mm-hmm.
Squats, I still think I'd be inclined to put it as accessories afterwards.
Mm-hmm.
Again, just I can see what you're saying about the pelvis and the trunk and the synchronicity between there. I just think putting yourself into that position, that flexed and rotated position, puts your discs into a vulnerable position before you then starting to load.
Yeah, and the thing as well is that rotation is this is where so I've been saying a lot to people is that, like, just think about, an explanation I've been saying to a lot of people recently is that as the volume of advice, so the volume of the audience goes up, which is like, so the advice given, as the volume of the audience goes up, so does how generic it is. So the reason why that's an important concept is because if, when you hear that something is good, that is like something is good, and that's a very, very assertive statement, when in context it could be a bad thing. So, I might say, yeah, we all need to rotate more and use thoracic rotation because it's good for our spine, which it is. However, in certain conditions, you don't want to promote that, because when we're doing squats and deadlifts, the whole point is that we don't rotate. And it's that element of rotation which we don't have the ability to control is what causes unilateral injuries. So, shoulders, SI joints, and all those, that we don't have the ability to stop ourselves rotating in one plane, so we fall in to where the instability lies. So yeah. The whiteboard of the version of the spine. Okay, I'll get into that in a second. I've been getting a reoccurring pain in the left side of my lower back that comes and randomly goes. When doing a hip hinge movement, it feels like it gets tighter and about to spasm. I presumed it might be the QL. How can I resolve this? Let me get my whiteboard out. Aaron, if you want to take that one.
Yeah, of course. So left side, you tend to find if it's unilateral, it's more than likely going to involve the sacroiliac joints and those kind of lower lumbar segments. The tightness, so with every back problem, you tend to find muscle spasm, whether that's sacroiliac joint, facet joints, disc. Muscle spasm is a consequence of what's going on underneath, as opposed to the cause of your back pain or tightness. So the first thing I do is identify what structure it is that you think the symptoms are coming from. So if it's sacroiliac joints, there's a test called the active straight leg raise test, which is basically like a straight leg raise test would use for neural tension to test the sciatic nerve, but you add some compression on your pelvis. You probably find this on YouTube. If not, I'll send you a copy, Chris, and you can perhaps populate it on your YouTube channel.
Mm-hmm.
The straight leg raise test, because it disarticulates both sides of your pelvis, it places quite a big demand onto the sacroiliac joints. When you add the external compression, so you're doing what the muscles should be doing but aren't doing, if that reduces your symptoms, then it suggests that you've got a sacroiliac joints and it's hypermobile. So then some core stability, some transverse abdominis work, that would be the way to resolve that. Difficult to say with the scant amounts of information we've got there what your tissue causing symptoms are. In my experience, the QL spasm is a consequence of, not a cause of your back pain.
Yeah, definitely agree. And again, there's lots of different things. And that's when a screening assessment, because nowadays when we're having to use Zoom for assessments, just seeing somebody move in ranges that they probably haven't even considered before can be useful. But like the split second you put into a treatment or an osteopath's hands, they'll be able to just touch a muscle and go, there's the issue, that's what it's stemming from. We address that and maybe we can get that. But in terms of resolving it, the reason why I couldn't speak absolutely is it could be coming from the feet, it could be coming from the hips, could come from anywhere else. You can try that test. But the way I would see it is that if it is spasming, I just see it as that the QL is a transverse muscle, is constantly working in every plane because it's doing flexion and extension, but it's also having to deal with the rotation of the hip, or the slight rotation through the lumbar vertebra. So I would look at trying to increase the length, so taking yourself into a slight posterior tilt. So if you were in the side that's painful, having the opposite side forward and the symptomatic side back in a slight lunge position, scoop your hips under and then lean over and lean forward slightly and just explore some ranges there. That is just to create that stretch through the muscle, and if it's spasming quite a bit, it doesn't have that ability to stretch. I'd then take yourself into that stretch position, so you can stretch the muscle through your own pelvic control by taking that posterior tilt, and then take really deep breaths in through your nose to expand the whole core muscles. And I'd do that, and that's how I would resolve it, and do like a flossing, which is just that slight lunge position, breathing in as you go forward, breathing out as you come back, and just finding different ranges. That might not be the solution, but it may take you down the rabbit hole of things that improve it. So
we did, I don't know whether you guys have heard of Aldoa stretches. So Aldoa is it's a fascial stretch. It's a concept designed by, I think it was Guy Voyer, who's not a French osteopath. On our feed, Mofo Body Mechanic feed, there's an Aldoa hip stretch, which is very similar to what Chris has just described. You'll find you're not just hitting psoas major, iliacus, you're also hitting QL. So it might be worth checking out that Aldoa hip flexor stretch, which is probably 2 or 3 days ago that we posted.
I've come across it myself, and it sounds absolutely awesome, but I'm purposefully not doing it just in case I figure it out myself. And then if
you can call it the Notoa.
Yeah. Well, this is the thing, is the way I see it is I looked at it and I was like, and I was thinking to myself, if I do the course and then post the things, then it looks like I'm copying it. Whereas if I just carry on, maybe I'll figure it out myself, and then I can't say so.
Yeah, I mean, I think the concept is essentially you're trying to pull the bottom away from the top. So it comes like a whole body stretch. And the argument is that fascia is continuous throughout the entire body. We talked in some of our podcasts, Chris, we mentioned this Anatomy Trains, Chris Myers.
Yeah.
Dissection with Chris, and he said that muscles, his contention is that we are one muscle divided into 600 compartments by fascia. And he proceeded to cut there was a cadaver on the gurney. He proceeded to cut the Achilles tendon, and then basically took the Achilles tendon and just pulled this big long string of muscle off. And it was the gastrocs came off, the hamstrings came off. It crossed over onto the opposite side glutes, went into the erectors on the opposite side, all the way up to the skull. So certainly from a continuous perspective, it would appear that we have some, despite the naysayers, it would appear that we have some continuity in our muscles from this fascial connection. And the Aldoa system works on the basis that it's stretching the bottom and the top and trying to take those two things away from each other.
I think the issue is that we had one side of the coin here and then the other side of the coin here. This was a couple of years ago, due to popular pop culture in the fitness industry, is that we had some people saying that fascia was the be all and end all and you should train it in specific ways, and then you had other people saying it doesn't really mean anything, it doesn't matter, and then everybody was trying to form an opinion. And the thing is that both of those guys are right in a sense. Like, when you're trying to squat, you're just trying to move the weight in the way that makes sense so you don't hurt yourself. Whether someone wants to come along and say you're training your spiral line, lateral line, superior, anterior line, it doesn't matter. You're just trying to squat the weight. But in terms of anatomy, is everything connected through physical anatomy? Yes, it is, and that's where it can be significant. So in terms, I think we've answered Rachel's question there with Aldoa. Might be something worth looking into. I don't ever, I'm not the biggest on always plugging my own thing, but I have put something together myself, which people will be able to access in regards to screenings and understanding movement. So you can look after that. Weird one. Sometimes when I'm bracing, particularly for squats, I get a pinching, catching feeling in my left upper rib cage. Any ideas? Oh, that sounds, I would immediately think thoracic outlet syndrome. What do you think, Aaron?
Yeah, I don't know. Top of my sometimes when I'm bracing, particularly for squats, I get a pinching, catching feeling in my left upper rib cage.
Is it? But I think we need to know with that one. Is it?
Front or back?
Yeah, anterior, posterior.
So is it anterior, posterior?
Is it upper like rib? Is it near the neck, the clavicle, or is it like just upper? As in like, because that's why there's a little bit more.
So give us a bit more information, Harvey.
A bit more information, please, Harvey, and we'll get back to that one. Is there a relationship between the adducter and obliques, transverse abdominis in regards to muscle activation and compensation patterns? Yes, there is. Okay. With that one in, that's a really, really, really good question. Is there a relationship with the, yeah, 100%. And what is, Henrik wanted to see a whiteboard session. So I might just quickly nip into that. But what we'll do is with Henrik's question and with Andrea's question, we will go through the whiteboard. We'll just take this last question before. So fortunately, guys, this will be the last question, and we'll nip to the whiteboard before we finish from Rach. So hyperlaxicity in normal times would be no problem, Anthony. So we regularly visit my physio and get some SI relief as this frequently locks up. Do you have any self-release recommendations that I'd be doing at the moment? Already doing a few things at home, but not getting much release as need to be achieved through hands-on work. Aaron, do you want to take that one? Because I know you've been achieving something there.
So I think the thing is with hypermobility or hyperlaxicity, if this is just at a joint level as opposed to body-wide level, the thing you'll find, if you keep releasing a hypermobile joint, it becomes more hypermobile. So you're almost setting yourself up for it locking continuously. And when we talk about locking, sacroiliac joint moves 15 to 18 degrees. You know, it's not a huge amount of movement. It's basically a nodding forwards and a nodding backwards, nutation, counter nutation. So it can get stuck, and there is an SIJ reset technique, which is an MET, so a muscle energy technique. I've posted a video of that, I think, on my Instagram feed. I think one of the recent posts, we did a sacroiliac joint reset, and it basically involves using your legs, trying to take the legs in opposite directions while you're doing an isometric contraction, so you're resisting that. Pillow between the knees. Once you've done that 3 or 4 times, squeeze the knees, and then you find that you get a click or a pop at the back and possibly at the front in the pubic symphysis region. So you could try that. But then once you've reset it, I think the important thing to note there, Rach, is you need to try and think about stabilizing. Now, the sacroiliac joints are a joint that's supported by ligaments rather. There's very few muscles that cross the sacroiliac joints. However, transverse abdominis acts like a force closure mechanism. So if you contract your transverse abdominis, it pulls the pelvis and therefore the sacroiliac joints together, and it creates a force closure mechanism. So that creates better stability. So I think as nice as it feels getting your joint, your SIJ released, try and get it released and then spend some time stabilizing, because that will save you some money in the long term.
100%. And I think, you know, what you guys will probably get by now is the amount of integrity it takes for Aaron to come across like that, because obviously he's a very, very busy individual. But you know, therapists, and this isn't directed at your physio in the slightest, Rach, but therapists do go business and finances first, you know, maybe principles second, which isn't bad. But I believe that if you go principles first, then the business will just follow. Because I've had it where when I was really into my strongman, when I really, really pursued it and was just squatting and deadlifting pretty significant load for my body weight, I was of the mindset that I train I go see my chiropractor every week. He cracks me back into place, and then I go train again. And I remember I did once ask, am I ever going to risk ever getting joint laxity? And it wasn't really communicated in the right way. So, I've now just got to make the fact that despite when I'm training, I can train to a very high level, which I'm very pleased with, and touch wood, not in any pain. But that joint's always compromised. It's never going to be the same as the right. Unfortunately, I've made my peace with it. It's just not going to be the same. And there's also other adaptations that occur due to that joint being slightly lax. So yeah, 100%. It is very important to see therapists, 4, 6, 8 weeks time. But if there is if you're constantly relying on seeing somebody for it to be released and cracked, and then you're good going forward, I would reassess your stabilization exercises and your training so that it's not required as much. But in your case, I do appreciate that there may be an issue there because of the hyperlaxity. But that's mainly for everybody else. Is just if you constantly need adjusting with spinal manipulation, which is high velocity, reassess your program.
And I think the thing is with adjustments is you get addicted to the looseness that you have after you've had an adjustment.
Yeah.
And then your brain starts to interpret that looseness as the normal rate, as like what it should feel like normally. Mm. So if I release someone's back, for 20 minutes, half an hour, your back feels loose. And what you end up doing, this is the reason why I think people crack the necks themselves, chasing that looseness feeling, which isn't normal. To feel loose like that. Like if I did that to a deadlift, powerlifter, before he went and deadlifted or squatted, he's probably going to blow a disc because I've essentially destabilized his spine by adjusting his back. Mm. So I think adjustments I use sparingly because I'm concerned that over adjusting people makes joints lax. It makes things hypermobile. And I think, like I say, as Chris was saying, I think it's about something that's going out of position is unstable. And in order to stop that from going out of position, it's about creating stability. Mm. Because it's not a quick fix. And I think that sometimes you just want that crack and it's done. It takes, a few weeks to create stability and create that sort of that situation where you don't need to keep having adjustments done.
Cool. I'm just going to, Aaron, if you could just make me the host again, please, so I can screen share.
Yeah, of course I can.
That'd be great.
How do I do that, buddy?
You just go over to my name and there'll be a scroll down and it'll say make host. It should say options and then make host.
It's not. Has that worked?
Let me see. I can screen share. So yep, it has worked. So it's all good. Yeah. Cool. And then you guys will be seeing my screen and then hopefully we can get that.
So the penis puppetry.
Yeah. Here we go. Everybody's at the ready. Everybody's I'm under pressure now because this is the bit that's going to make it on social media. So, right, the spiral, the helter-skelter. So we'll go through the spiral and the helter-skelter, then we'll go through that cross-sectional between the obliques and the adductors and all that, because that's seriously cool stuff. So this is the back of the head. So mastoid process, we've got the back of the head here. So just going to put this X marks the spot in that point there. Now, the interesting thing about the Splenius Capitis, which if I go here like that and maybe draw a different color, is that this muscle is going to come across and go like that in some way. I'm not drawing that the best, but it's going to go through, and we have this point here, which is C7, and we're going to go through down to T3, and I'm just going to draw T5 as well, or just put it in there in that position. And when we were saying about fascia and how everything works and how it's interconnected, is that, well, yeah, whether fascia is a thing, well, fascia is a thing, but whether fascial trains are a thing and the significance is just going to boil down to whether things share origins and insertions and it's significant. So we're going to go from here, and it's going to get drawn into around here, T3. So this is that Splenius Capitis. Now, again, if we think about other things that insert from an anterior perspective, we've then got the SCM, so the sternocleidomastoid, and that is going to be inserting onto the mastoid process itself. So then looking from side to side and rotating our heads, in any format is going to be massively dictated by this muscle, because we've got this link. This mastoid process acts as like the top of a bridge or the top of a tent, going from anterior to posterior. So we've got this muscle here, which has gone into the spine, C7, T3, T5, and now it's going to follow through, and it's going to go into the, which I'm going to draw, actually I'm going to draw here, in, rather than X now, I'm going to put something round about here. I'm going to put across there and across there, and we've got the inferior angle and we've got the superior angle of the scapula. And now if I draw another muscle that's going to come round like so, we've got the rhomboids minor at the top, and then we've got the rhomboids major that's going here into this point like so. And if we think about that helter skelter, how it wraps around something, it wraps around a structure, it goes like this and then it goes to the front. So this is the posterior aspect, and now it's going to go through and it's going to wrap itself round. Now if I was to continually draw the scapula here and just go through and then say that's the version of the scapula, what it should look like, it's hard to draw from an anterior perspective, but there, this medial border is where the serratus anterior are all going to originate, and then they're going to insert into the ribs, from ribs 1, which are going to be up here, all the way down to the 10th rib down here. So we're going to pull that round like so. And this allows, the serratus anterior allows the scapula to go forward into protraction, but it also plays a big role in taking emphasis off the upper traps, because if this scapula doesn't have the ability to move around anterior or move around the front of the body, whether it's in slight elevation or slight depression, which one will depend on the trapezius or the rhomboids, then the upper traps will take over. That then carries on, and now if we go from an anterior perspective, say this is the trunk here, and we're going to go from here to here. So this is left rib, this is the right rib cage or right scapular border, and then this is the left iliac of the hip. Now this is the medial border here. It's come round, and these muscles have gone round like this, these like finger-like projections that are going into the rib cage. And then what we have here now is, if we were thinking of a muscle, these are going to eventually turn into external obliques, which is we're going at a diagonal in this position. Remember, this is the anterior portion of the rib cage here. So we've got external obliques, but then when we're thinking about all these other different muscles, these muscles we talked about in a Union Jack fashion, we've got Rectus Abdominis, we've got the TVA that are going across here, got external obliques that are going this way, and internal obliques which are a little bit deeper and going that way. And obviously they should cross in the middle. I've just missed. So we've got these muscles here, and these are going to allow us to rotate. We can go forward into like a diagonal crunch. We can flex, we can extend, we can spin either side. But really what we're thinking about in this pattern is that when we're walking or when we're moving ourselves forward, this part here, or if I draw another cross, in a certain phase of the walking mechanism needs to go towards this opposing the contralateral hip. And then that, if we think about insertion points, is going to go through. And if we look at all these insertion points, we have where the hip starts. And if I draw it in a different color now, if we go from here, we can think that it goes round through here, wraps, now it's posterior, it's going round, and it's going up into the back of the head like that. So we have this line that goes across that mechanism in the transverse plane. And that's what I mean about that helter-skelter that wraps around the body. Now, if we go to the other question, or we carry on from here, because it just makes perfect sense to carry on, is that if we have this pelvis now, we've got all the things that are occurring in this pelvis, all the anatomical features. I'll try and not draw a horrendous picture, but let's just say this is the initial tuberosity or the ischium. This is the pubis. If we're thinking about the pubis symphysis here as an attachment, the pubis symphysis is the attachment or the insertion point of the rectus abdominis, which I've established is this muscle here. What else is it? Well, it's also the origin of the adductor longus, and then a little bit more to the side is going to be the adductor brevis. So then if I was to just quickly draw in a femur on this side, and I know me drawing a femur is a bit risky, but I'm just going to do a line here, which is the
This
femur.
is what I've been waiting for, Chris.
Yeah, this is the moment. I'm not doing
They're not
No,
interested in the helter-skelter analogy. They just want to see your
you
penis.
just want to see a penis drawing, yeah. But so we've got this, and it's just going to remain a line, guys. Sorry to disappoint. And now we've got this section here, which is going to be your adductor, and it's going to fan down like this, and that's the longest. And as we go round, it's going to be the it's going to get further down. As if we're going further more towards the ischial tuberosity, it then become the magnus, which is again more of a hamstring. But in terms of the adductors with internal rotation abilities, it is connected through there. So that is actually a continuation, or could be a continuation of that line if we can carry on with that helter-skelter theme. But really, with this adductor, these guys are constantly shortening and lengthening when we walk, but we just think, oh, an adductor, that's frontal plane. So we think an adductor stretching is going from here, and then if we were to stretch it, we would go out here. This is abduction, this is abduction, and abduction, that's terrible, but abduction is testing the length tension in the adductor. Yes, it is. But when we consider what these muscles can do from a structural perspective, they're constantly spinning into internal and external rotation as we're walking, squatting, deadlifting, doing anything. So if we don't have the ability to hold the trunk still, and these guys are tight or short or whatever, so these guys can't go through their full range of motion, then you're going to get some rotation in the spine or rotation in the hips when you're lifting. So in answer to your question, is there a connection between the adductors and the midsection? 100%, and that's what makes exercise programming and design really cool, is you can play around with positions and all these other things that improve how well you move in all these components. So what I will do is, because we are going over, I'm going to leave it there, guys. We'll go through. Yeah, and a lot of people, so some people are getting off, that's absolutely fine. But yeah, we'll leave it there. I can't remember what I said. What's next week, did we say? Or something to do with...
Was it wrist and forearm? Forearm and wrist?
Yeah, forearm and wrists.
Yeah.
So forearm and wrist next week, and we'll go through. This will be uploaded onto YouTube later today. And next week we'll do elbows, knees again. We've done knees already, but we'll do elbows, knees, and foot and ankle and wrists, and we'll go through. We already spoke about it off air. That is obviously a very intricate topic, and it's not the sexiest, but it is relevant. So if anybody really wants to upskill and really think about elbow and knee and wrist pain, that'll be one for you. Cool. So I'm going to stop there.